During the Dutch famine of World War II, half the women in affected areas just simply stopped menstruating.
Yeah, entirely.
And birth rates plummeted by an astounding 53%. I mean, it was this massive population-wide reproductive shutdown. And today, in modern clinics, we actually see that exact same biological lockdown happening in elite athletes.
Which is wild to think about.
It really is. So welcome to the Deep Dive. We are talking directly to you today, the second-year medical student. You know, you're just about to step out of that comfortable, predictable world of textbook biochemistry and into the beautiful, chaotic reality of patient care on the wards.
And it is such a critical transition period for you. Because, I mean, when you're looking at textbook, a metabolic pathway is static, right?
It's just lines on a page.
Exactly. But when you have a living, breathing patient sitting right in front of you, you're suddenly looking at this diagnostic landscape that is just constantly shifting.
Which is exactly why we've pulled a very specific stack of sources for you today. We're looking at a really comprehensive set of clinical nutrition slides from Dr. Helena Imitai, dated July 2026.
And this material is so good because it doesn't just tell patients to, like, eat healthy.
No, it goes way beyond that. It maps out exactly how human metabolism and nutritional needs completely transform across the entire life cycle.
Because what a body requires to actually synthesize a new human being at the cellular level is it's vastly biologically different from what it needs to combat the physiological erosion of your 80s.
So the overarching theme we're digging into here is that fertility, growth, aging, they are not isolated events. They were deeply metabolically integrated.
Yeah, and we can actually start by looking right back at that Dutch famine data you mentioned.
Let's do it.
Because we usually think of fertility as this isolated, almost protected reproductive function, right? But the data clearly proves that fertility is entirely tethered to body composition and metabolic security.
Let's really unpack the mechanism there, because the source material makes this really sharp distinction between chronic and acute undernutrition.
Right. They present very differently. Like
chronic undernutrition spanning years, that generally leads to low birth weight, frail infants, that sort of thing. But acute undernutrition, a sudden, sharp drop in caloric intake, like a famine that actually shuts down fertility altogether.
And the evolutionary logic behind that is just fascinating when you look at the endocrinology.
How so?
Well, the female body requires immense, continuous energy reserves to gestate and lactate, right?
Yep.
It's this hugely biologically expensive process.
Oh, absolutely.
So when the body senses an acute energy deficit, it immediately initiates this triage protocol. The hypothalamic pituitary gonadal axis, the HPG axis, it's just exquisitely sensitive to metabolic stress.
So it's sensing a lack of incoming energy. But what's the actual signal there? I mean, is it just low blood glucose?
It's a bit more complex than that. The hypothalamus is constantly monitoring leptin levels from adipose tissue, insulin levels, and overall energy availability.
Okay.
So when those markers drop suddenly, the hypothalamus just suppresses the pulsatile release of gonadotropin-releasing hormone, or GnRH.
Ah, got it.
And without that pulsatile GnRH, the anterior pituitary completely stops releasing luteinizing hormone and follicle-stimulating hormone.
The downstream effect being anovulation and amenorrhea, the reproductive system literally just goes offline.
Exactly. And we see this quantified too. For a normal weight woman, a weight loss of just 10 to 15% of her usual body weight is enough to trigger this hypothalamic suppression.
Wow, just 10 to 15%. And it's not just a female physiological response either, which is interesting.
Not at all.
Yeah, the slides note that in men, a 25% weight reduction entirely ceases sperm production.
Shuts it right down.
Yeah, and even just a 10 to 15% drop significantly decreases sperm viability and motility. The factory it closes its doors.
It really does. But let's bring this to the modern clinic for a second.
Right, because famines aren't what you're typically seeing on Tuesday morning.
Exactly. Imagine a patient comes into your office. She's, say, a competitive bodybuilder or a marathon runner. She looks incredibly fit. She's the absolute picture of health, but she's presenting with subfertility.
And this is a massive trap that many clinicians fall into.
Huge trap. We tend to conflate being athletically fit with being metabolically secure.
Yeah, and the slides highlight some really alarming data on female athletes. Like, competitive bodybuilders have an 86% incidence of absent menstrual cycles compared to just 13% in sedentary women.
86% is staggering.
And long-distance runners doing over 70 miles a week, they have a 43% incidence.
Right, because their intense training regimens, combined with these really strict dietary caloric deficits, they're stripping away that essential body fat.
They're essentially mimicking the metabolic stress of a famine.
Exactly. Even if they have a pantry totally full of food at home, the HPG axis doesn't know they're, cutting for a competition. It just senses starvation.
Which is why the very first line of intervention for subfertility in these specific patients shouldn't be jumping straight to Clomid or IVF.
Absolutely not. It should be restoring energy availability to basically reawaken that HPG axis.
Right. But, the metabolic scale definitely tips in both directions. The source material also explores how excess body fat disrupts fertility, and the mechanism there isn't just a lack of energy, it's actually an overnode of oxidative stress.
Which is a crucial point. Adipose tissue is not just some passive storage depot. It's a highly active endocrine organ.
Right.
So when a patient is obese, that expanded adipose tissue creates systemic inflammation. Macrophages start to infiltrate the fat tissue, releasing inflammatory cytokines.
And that creates an environment that's just incredibly rich in reactive oxygen species, or ROS.
Yes. And those reactive oxygen species are highly, highly destructive at the cellular level.
Especially to gametes, right?
Oh, massively. In men, sperm cell membranes are packed with polyunsaturated fatty acids. They absolutely need those fatty acids to maintain the fluidity required to, swim and eventually fuse with an egg.
But the ROS come in and ruin that.
Right. The ROS attack those fatty acids in a process called lipid peroxidation. It literally degrades the sperm's membrane, destroying its motility and its ability to execute the acrosome reaction, which you need for fertilization.
Wait, I read it can even fragment the DNA inside the sperm nucleus. Is that right?
Yeah, exactly. It shatters the DNA. And the hormonal disruption is just as profound. In women, obesity leads to higher peripheral conversion of androgens to estrogens right there in that expanded fat tissue.
Which is paired with elevated leptin and insulin resistance.
Exactly. All of which heavily disrupt follicular development. And in men, obesity is associated with lower levels of testosterone and increased estrogen, which directly impairs sperm maturation.
Which brings us right back to the clinical applications for you, the listener. As a medical student, you have to look at their overall nutritional status.
You really do. Are they getting adequate antioxidants to quench those free radicals? Are they getting enough zinc?
Yeah, the slides really hammer home that lower zinc status in men is directly related to poor sperm quality, abnormal morphology, and disrupted testosterone synthesis.
Because zinc is a critical cofactor for over 300 enzymes, right? Including the ones involved in nucleic acid synthesis.
And the lifestyle factors go way beyond just macronutrients, too. Caffeine and alcohol are huge culprits here.
Oh, massive.
Yeah, drinking more than 300 milligrams of caffeine daily, which honestly is really just a couple of strong cups of coffee that can decrease the chances of conception by 27% per cycle.
Which is a huge drop for just 2 cups of coffee.
It really is. And heavy alcohol intake severely disrupts both menstrual cycles and testicular function.
We also we have to consider pre-existing clinical conditions that become highly volatile during this preconception phase.
Like PCOS.
Right. Polycystic ovary syndrome. It's characterized by profound insulin resistance, hyperandrogenism, and anovulation. The hyperinsulinemia directly stimulates the ovaries to just overproduce androgens.
So dietary modification to improve insulin sensitivity is basically the absolute cornerstone of managing PCOS and restoring ovulation.
Exactly. Then there's phenylketonuria, or PKU. And this is a truly terrifying physiological scenario if it's left unmanaged.
It really is, because patients with PKU have a deficiency in the enzyme phenylalanine hydroxylase, meaning they just cannot convert the amino acid phenylalanine into tyrosine.
Right. So if a woman with PKU does not strictly adhere to a low phenylalanine diet before conception and during early pregnancy, the phenylalanine just accumulates to massive toxic levels in her blood.
And it crosses the placenta?
It readily crosses the placenta and competitively inhibits the transport of other essential large neutral amino acids into the fetal brain.
Oh, wow. So it's actively blocking the good stuff from getting in.
Exactly. It essentially starves the developing fetal central nervous system of the vital building blocks it needs.
Leading to what?
It leads to a 92% chance of severe intellectual disability, microcephaly, and congenital heart defects in the newborn.
The direct line there between maternal diet and fetal brain architecture is just staggering.
It's immediate and profound.
And we see a similar gut-to-gonad connection with celiac disease, too. Untreated celiac in men leads to delayed sexual maturation and hypogonadism.
And in women, it leads to amenorrhea and miscarriages.
Because the autoimmune destruction of the intestinal villi leads to this massive malabsorption of those critical micronutrients we talked about, like zinc and folate.
But the incredible thing is, simply implementing a strict gluten-free diet resolves the inflammation, heals the gut lining, and it actually restores androgen activity and fertility.
It's all connected. So the preconception phase is entirely about setting the metabolic stage. But once conception actually occurs, the physiological demands shift dramatically, and they shift immediately.
And the first major structure to form isn't even the fetus itself. It's the placenta. The slides really emphasize that we need to stop thinking of the placenta as just like a passive biological filter between the mother and the baby.
Yeah, that's such a fundamental misconception, isn't it?
It really is. The placenta is an incredibly complex, highly metabolically active organ. I mean, it develops before the fetus even begins its rapid growth phase.
Because it has to set the supply lines up first.
Exactly. It requires a massive proportion of the mother's energy and nutrients just to build and maintain its own cellular structure. It's synthesizing its own hormones, like human chorionic gonadotropin and human placental lactogen.
And those hormones actually alter the mother's metabolism, right? To ensure a steady supply of glucose straight to the fetus.
Right. They essentially hijack the maternal metabolism.
Right.
And the maternal and fetal blood, they never actually mix.
Which is always so wild to think about.
The blood vessels just interweave incredibly closely to exchange nutrients and oxygen via active and passive transport.
Okay, so the development of the placenta and the early embryo introduces this really key concept of critical windows.
Yes.
And this is a vital concept for you, the second-year medical student, to really internalize. Different fetal organs have these highly specific, very narrow time frames where their precursor cells are dividing rapidly to form the foundational architecture.
And the most famous example of this, which the slides highlight, is the neural tube.
Right.
The neural tube eventually becomes the brain and the spinal cord, and it develops and closes completely within 21 days of conception.
And clinically, that 21-day mark is paramount because at 21 days, most women do not even realize they are pregnant.
Exactly. The menstrual cycle might just be a few days late. You wouldn't even necessarily take a test yet.
Yet the foundational architecture of the central nervous system is already being finalized.
Which is terrifying, but it's exactly where folate comes in.
Right, we always hear, take your folic acid, but let's break down the actual biochemistry for the med students. Why is folate so non-negotiable for this specific 21-day window?
Well, folate is a crucial one-carbon donor in the folate cycle, which is directly responsible for the synthesis of thymidylate and purines.
So basically, it is a non-negotiable building block for DNA replication.
Exactly. During a critical window like neural tube closure, cells are dividing at this explosive exponential rate. If there is a folate deficiency, DNA synthesis just stalls.
The cells simply can't divide fast enough.
Right. And because they can't divide, the neural tube simply fails to fold and close properly, resulting in catastrophic neural tube defects like spina bifida or anencephaly.
And the kicker here, because it's a critical window, is that if a patient misses that 21-day mark, taking massive amounts of folate on day 40 isn't going to fix the issue.
No, it's too late.
It's like a 3D printer running out of a very specific ink. You can't just slap the ink on 20 days later and expect the model to fix itself.
Yeah.
You can't go back and retroactively close the neural tube. The architecture is permanently altered.
That's a perfect analogy, and that is the crucial clinical distinction between critical development and continued development. Damage during a critical window is just irreversible.
And we see the exact same irreversibility, but through a toxic mechanism this time with fetal alcohol syndrome.
Oh, absolutely. Ethanol crosses the placenta freely.
The placenta doesn't filter it out at all.
Cannot filter it.
Yeah.
Ethanol is a small, uncharged molecule, so it diffuses easily right across the placental barrier. And the fetus has virtually no hepatic enzymes, no alcohol dehydrogenase to metabolize it.
Oh, wow. So it just sits there.
Exactly. The ethanol and its toxic byproduct, acetaldehyde, just accumulate rapidly in the fetal circulation.
The slides show this visually, and man, it is a stark image. Dr. Nedlin-Weiss' presentation actually contrasts the physical brain of a normal 6-week-old baby with a fetal alcohol syndrome brain side by side.
And the pathophysiology behind that image is profound. The ethanol creates this massive oxidative stress within the developing fetal brain, and it actually induces apoptosis, programmed cell death directly in the neural crest cells.
Plus, it restricts placental blood flow, right? Causing fetal hypoxia.
Yes. So you have a severe lack of oxygen combined with direct cellular toxicity. That is exactly why the FAS brain in those slides is visibly shrunken. with a profound loss of overall white and gray matter volume.
The surface folds, the gyri and sulcite, they're just smoothed out. It's devastating.
It is a permanent architectural deficit caused by completely disrupting cellular division during a critical window.
It's definitely a sobering reality of fetal vulnerability, but, even after a healthy birth, the metabolic demands don't slow down. If anything, they accelerate.
Oh, they skyrocket.
Because the sheer velocity of infant growth is unmatched at any other point in the human life cycle.
Just think about it. An infant will double its birth weight by 6 months and triple it by 1 year.
That's insane.
It is. And to sustain that, their nutritional requirements per kilogram of body weight are astronomically high compared to an adult. We're talking about roughly 90 to 100 kilocalories per kilogram for an infant.
Versus what for an adult?
Versus maybe 25 to 30 kilocalories per kilogram for an average adult.
Right. So to fuel that explosive growth, the macronutrient profile of their food has to be entirely different from ours.
Completely different.
The source material actually compares the recommended adult diet to the composition of human breast milk. An adult diet is typically, around 53% carbohydrates, 21% protein, and 26% fat.
Right.
But breast milk completely flips those ratios. It is a massive 55% fat, 39% carbohydrates, mostly in the form of lactose, and only 6% protein.
And we really need to look at why that 55% fat content is biologically necessary. Because it's not just about providing a dense source of calories for weight gain, though obviously that is important.
Right, there's more to it.
That fat is incredibly rich in essential fatty acids, particularly docosahexaenoic acid, or DHA.
And DHA is a massive structural component of the human brain, right?
Precisely. DHA is preferentially incorporated into the phospholipid bilayers of neuronal cell membranes and the myelin sheaths that insulate nerve fibers.
So it's building the wiring.
Exactly. The infant's central nervous system is still rapidly expanding and wiring itself outside the womb, and it requires this constant, massive supply of dietary DHA to build those neural networks.
Okay, that makes sense for the fat. But what about the protein? 6% seems incredibly low for a human that is literally tripling its body weight in a year.
Well, it is low in absolute quantity, yes. But the biological value and the bioavailability are completely unparalleled. The primary proteins are way dominant, specifically alpha-lactalbumin, which is highly, highly digestible.
So they use almost all of it.
Exactly. It also contains lactoferrin, which is an iron-binding protein that actively inhibits the growth of iron-dependent pathogenic bacteria in the infant's gut.
Oh, so it's providing a crucial immunological defense while the infant's own immune system is still immature.
Spot on.
But the slides are very clear that breast milk isn't, a permanent silver bullet. Right around the 6-month mark, a critical shift happens. Breast milk alone actually becomes nutritionally inadequate.
Yes. And the most urgent deficit right at that 6-month mark is iron.
Why iron specifically, then?
Well, during the 3rd trimester of pregnancy, the fetus builds up a robust hepatic store of iron in the liver. But because breast milk is naturally quite low in iron, the infant relies heavily on those endogenous stores after birth.
So they're just depleting the savings account.
Exactly. And by 6 months, as the infant's blood volume has expanded so rapidly to keep up with their growth, those hepatic stores are totally depleted.
Which is exactly why the introduction of complementary foods at 6 months is a hard, fast clinical guideline.
Non-negotiable.
Because if you don't introduce iron-fortified cereals or pureed meats, the infant will rapidly develop iron deficiency anemia.
Which severely impairs both cognitive and motor development.
And they also need additional vitamin C, right? Which enhances the absorption of that non-heme dietary iron.
Exactly. So as that infant grows into a toddler and eventually a child, we approach the second most volatile metabolic period in the life cycle, adolescence.
Ah, yes. The psychosocial and metabolic hurricane.
That's the perfect name for it.
Because adolescence is the only period that even rivals infancy in terms of rapid physical growth velocity. But as a clinician, you can't just look at a teenager's chronological age to determine their nutritional needs, can you?
No, chronological age is practically useless in pediatric adolescent medicine. I mean, a 13-year-old could still physically look like a child, or they could have the biological build of a young adult.
So you have to assess their biological age.
Yes, which means utilizing Tanner's staging to rigorously track their secondary sexual characteristics and overall physical maturation.
Because the hormonal triggers for these massive growth spurts dictate entirely different physiological goals based on biological sex.
Correct.
For instance, females typically hit their peak growth velocity much earlier, right around ages 11 to 12.5.
Yes, and that's driven primarily by the rising levels of estrogen from that reawakened HPG axis we talked about. During this peak velocity, females gain an average of 21 pounds.
But crucially, a significant portion of this weight is the deposition of subcutaneous fat.
Exactly, which ties perfectly back to what we discussed in the preconception phase. Right?
Oh, right. The female body is actively building the lipid reserves necessary to initiate menarche and basically sustain potential future reproductive demands.
It's all connected. Now, males, however, hit their peak growth velocity later, usually around 13 to 14 years old. Their growth is driven by massive, massive surges in testosterone.
And they gain an average of 34 pounds. But unlike females, this weight is almost entirely lean body mass. Right?
Yes, it's a massive expansion of skeletal muscle and bone density.
And because of this rapid expansion of tissue in both sexes, the source material flags two critical micronutrient crises during adolescence: calcium and iron.
Let's take calcium first because it's so critical. Adolescence is the absolute critical window for bone modeling. This is the period of the highest calcium absorption capacity in the entire human life cycle.
So the body's just desperately trying to lay down peak bone mass.
Exactly.
The bank account is open for deposits, but it's going to close soon.
That is a great way to think about it. By the late teens, the epiphyseal plates in the long bones actually fuse, and the opportunity to significantly increase bone density diminishes rapidly.
But the data shows a massive proportion of teenagers, particularly females, just completely fail to meet that 1,300 milligrams per day requirement.
They fall drastically short.
Which leaves them immediately vulnerable to stress fractures if they're athletes, and it essentially guarantees they will face osteoporosis when they hit menopause and lose the protective effect of estrogen.
It's a disaster waiting to happen.
Yep.
And the second crisis point is iron.
Right, because of the blood volume changes.
Exactly. For females, the onset of menstruation introduces a constant monthly loss of iron that must be continuously replaced. For males, that massive accretion of lean muscle mass we mentioned requires a concurrent massive expansion of blood volume.
Because they need the iron to synthesize the hemoglobin to actually oxygenate all that new tissue.
Precisely. And if they're shifting toward plant-based diets, which is increasingly common among teens right now, their risk profile just skyrockets.
Because the non-heme iron in plants has significantly lower bioavailability than the heme iron in meats.
Right. But this is where the biochemistry violently collides with psychology.
Oh, for sure. Because you cannot just hand a 15-year-old a complicated chart on hemoglobin synthesis and expect them to suddenly eat more spinach.
It will never work. Adolescence is defined by this massive psychosocial shift called social reorientation.
Where their parents are no longer the center of their universe, their peers are.
Exactly. And they are incredibly present-oriented. As a medical student, you have to realize that warning a teenager about, say, getting a heart attack at age 55 is clinically useless.
They just don't care.
They do not possess the neurocognitive maturity to alter their current behavior for a consequence 3 decades away.
So the clinical messaging has to pivot to their immediate reality.
It has to. You have to focus on tangible, short-term benefits.
Like optimizing their sports performance or having more energy to get through the school day or even just clearing up their skin.
Exactly. You have to appeal directly to their growing need for autonomy.
But that autonomy is being relentlessly manipulated by the external environment. I mean, the slides cite a staggering 2025 study revealing that 90% of food and beverage posts by influencers on platforms like Instagram and TikTok promote HFSS foods.
Foods high in fat, sugar, and salt.
90%. And the danger there is the parasocial relationship. It doesn't feel like a corporate advertisement to a teen. It feels like a trusted friend giving them a personal recommendation.
It completely bypasses their critical filters.
So the clinical question becomes, how do parents maintain any sort of healthy environment when they are actively losing influence to peers and social media algorithms?
It's tough.
Yeah.
But the slides introduce a really fantastic framework for this called Satter's Division of Responsibility, or SDR.
Right. And this basically completely removes the battleground aspect of feeding, doesn't it?
It does. SDR clearly defines the boundaries. The parents are responsible for the what, when, and where of food.
So they control the perimeter.
Exactly. They decide what groceries even enter the house, and they establish structured family mealtimes. But the teenager retains total responsibility for the whether and how much.
You give them the autonomy to regulate their own satiety cues. You don't force them to clean their plate, and you definitely don't restrict them if they are still hungry. You just provide the healthy scaffolding.
And the data supporting this kind of structured family environment is just incredibly strong.
Right.
Even amidst all the chaos of peer pressure and digital marketing, eating at least 5 family meals a week is associated with a 35% reduction in the risk of a teen developing disordered eating behaviors.
Wow. Which brings us to arguably the most dangerous clinical territory of adolescence and young adulthood. Eating disorders.
Yes.
And as a future clinician, it is absolutely vital to understand that this is not a binary switch. Patients don't just jump from healthy to anorexia nervosa. There is a vast, insidious middle ground of disordered eating.
It's a continuum. Chronic calorie counting, orthorexia, rigid food rules, profound guilt after eating these might not meet the strict psychiatric diagnostic criteria in the DSM, but they inflict severe metabolic and psychological distress.
And they demand clinical intervention.
They absolutely do.
But when we do look at the formal psychiatric criteria, the DSM-5-TR actually made a monumental shift in how we diagnose anorexia nervosa, or AN. They completely removed the amenorrhea criterion.
Which was a long overdue correction. Previously, for a female patient to be formally diagnosed with AN, she had to have lost her menstrual period.
But requiring amenorrhea immediately excluded all male patients and premenarchal female patients from receiving a formal diagnosis.
Which is awful because it meant their life-saving interventions were often delayed or outright denied by insurance simply because they didn't fit a flawed checklist.
Exactly. So now the core criteria for AN are focused on the restriction of energy intake, leading to significantly low body weight, an intense pathological fear of gaining weight, and a severe distortion of body image.
And the diagnostic thresholds were also lowered for bulimia nervosa and binge eating disorder. The required frequency for binging and compensatory behaviors like self-induced vomiting or excessive exercise that was dropped from twice a week to just once weekly for 3 months.
Because the medical complications don't wait for a twice-a-week schedule.
They really don't.
The systemic damage of these disorders is terrifying. For a patient with severe anorexia nervosa, say with a BMI of 10.5, the slides note a 45% chance of premature death.
The body literally begins to cannibalize itself just to keep the brain and heart functioning.
But eventually, the heart muscle itself wastes away.
Yeah, you see severe bradycardia, where the resting heart rate can drop into the 30s, and dangerous hypotension. The gastrointestinal tract loses its motility, resulting in severe gastroparesis, where food just sits in the stomach, unable to empty.
No, wait, hold on. This is where I need to challenge the source material for a second.
Go for it.
As medical students, we have had this mantra, start low, go slow, drilled into our heads when it comes to refeeding severely malnourished patients, right?
Very true.
We are taught that if you reintroduce calories too quickly, you trigger refeeding syndrome. You get this massive insulin spike that drives phosphate, potassium, and magnesium straight into the cells, leading to fatal hypophosphatemia and cardiac arrest.
That is the textbook fear, yes.
But the slides mention the UCSF STRONG trial, which seems to completely throw start low, go slow out the window. How is dumping higher calories into a starved patient suddenly safe?
It's an excellent pushback, and honestly, it represents a massive paradigm shift in clinical nutrition.
Okay, lay on me.
The traditional start low, go slow protocol was rooted in a very real, valid fear of refeeding syndrome. But in practice, it often meant we were keeping starving patients in a catabolic state for days after admitting them to the hospital.
We were essentially underfeeding them while they were on bed rest.
Exactly. We were prolonging the starvation. So how did this STRONG trial get around the electrolyte crash?
Yeah.
By aggressively decoupling the calorie increase from the electrolyte management.
Okay.
The trial demonstrated that if you closely monitor and proactively supplement phosphate, potassium, and magnesium from day one, you can safely initiate higher calorie refeeding protocols.
Oh, I see. So you just front load the electrolyte.
Exactly. By doing this, patients achieved medical stability 3 days faster, and it saved the healthcare system roughly $20,000 per intervention. You just have to manage the biochemistry proactively rather than starving the patient defensively.
Wow. But even when you do get the calories in, the patient's physiology still fights back, doesn't it? The source material details this fascinating precision nutrition research on the gut microbiome during starvation, and it's incredibly insidious.
It is. The microbiome adapts to survive. In a healthy gut, bacteria ferment complex carbohydrates into short-chain fatty acids like butyrate, which fuels the intestinal cells. But during the prolonged starvation of anorexia, The lack of dietary fiber forces a microbial shift. The bacteria actually begin to degrade the protective mucin layer of the gut lining just to survive.
And they shift their metabolic output away from butyrate and toward acetate.
Yes, and acetate acts as a massive biological trap during renourishment.
Because it's a quick fuel, right?
Precisely. It is rapidly absorbed into the portal vein and transported straight to the liver, where it is highly efficient at driving lipogenesis, the creation of fat.
It's an evolutionary survival mechanism to hoard any available energy during a famine.
But clinically, it means the malnourished gut tissue itself remains starved of its preferred fuel, butyrate, while the body aggressively tries to convert any incoming calories straight into fat.
It makes the physical process of refeeding incredibly uncomfortable and metabolically inefficient.
It perfectly illustrates why eating disorders are so complex to treat. You aren't just telling someone to eat. You're trying to rehabilitate a physiological system that has fundamentally reprogrammed itself for famine.
And we see equally catastrophic reprogramming with the purging behaviors in bulimia nervosa, too.
Oh, definitely. Self-induced vomiting causes a profound volume depletion and acid-base imbalance,
Because when a patient vomits frequently, they are losing massive amounts of stomach acid.
leading to metabolic alkalosis. And to compensate for the volume loss, the kidneys activate the renin-angiotensin-aldosterone system.
The kidneys are desperately trying to hold on to sodium and water just to keep the blood pressure up.
But aldosterone exchanges sodium for potassium. So the kidneys dump potassium into the urine to save the sodium.
Oh, wow.
This, combined with the potassium lost in the vomit itself, leads to severe hypokalemia, dangerously low blood potassium levels.
And potassium dictates the electrical repolarization of the heart.
Exactly. Severe hypokalemia prolongs the QT interval on an EKG, which can rapidly deteriorate into torsades de pointes,
Yeah.
which is a lethal ventricular arrhythmia.
That is why bulimia can cause sudden cardiac death, even in patients who appear to be at a normal weight.
It's a silent killer.
Okay, let's bring this right down to the clinic floor for a second.
Let's do it.
As a medical student, I might have a patient sitting on the exam table. They're at a normal weight, or maybe they're hiding weight loss under heavy, baggy clothes. They are smiling, making eye contact, and completely denying any issues with food. What are the undeniable physical tells I should be looking for during a standard physical exam?
Early recognition is everything here. First, look at the dorsum of their hands. You are looking for Russell's sign.
Russell's sign.
These are calluses, abrasions, or even scarring on the knuckles.
Oh.
They are caused by the repeated mechanical trauma of the knuckles scraping against the maxillary incisors during the act of inducing the gag reflex.
And the slides heavily emphasize that dentists and general practitioners are often the true first line of defense because the mouth tells the story before the psychiatric symptoms become undeniable.
You are looking for a very specific pattern of dental erosion called paramolysis.
Paramolysis.
The chronic exposure to highly acidic gastric contents during vomiting demineralizes the tooth enamel. But it doesn't affect all teeth equally.
Right, because the tongue protects the lower teeth during vomiting.
Exactly. So the acid damage is highly concentrated on the palatal surfaces of the maxillary interior teeth, basically, the backs of the upper front teeth.
The enamel is literally eaten away, leaving this smooth, glossy, yellowish surface where the underlying dentin is exposed.
Often with fragile, notched whiting edges. It is a massive clinical red flag.
So we treat the acute crises of youth, we manage the vitals, and we refer to multidisciplinary care. But as we move forward in the life cycle, the nature of the metabolic threat changes.
It shifts gears completely.
We transition out of the acute physiological warfare of adolescence and into the slow burn of adulthood.
These are the chronic diseases of lifestyle, or CDLs. Heart disease, type 2 diabetes, certain cancers.
These diseases don't happen overnight. They are the result of decades of metabolic friction. And the epidemiological evidence showing how deeply tied these are to lifestyle environment rather than just raw genetics is really undeniable.
The slides actually highlight two historical inflection points that prove this perfectly. First, look at Europe during World War II.
Right, the rationing.
The extreme wartime rationing led to a massive population-wide decrease in the consumption of meat, dairy, refined sugar, and saturated fat. Concurrently, public health officials recorded a pronounced, unmistakable drop in the incidence of coronary heart disease and type 2 diabetes mortality.
And the moment the war ended and affluent, westernized diets returned, the disease rates skyrocketed right back to their pre-war trajectories.
It's a perfect natural experiment. The second example is the classic migrant studies, When Japanese citizens migrated to Hawaii and California in the mid-20th century, they adopted a Western lifestyle and diet.
And within a single generation, their entire disease incidence profile
It
shifted.
was incredibly rapid.
They moved from the typical Japanese epidemiological pattern, which historically featured high rates of stomach cancer, often linked to high salt, preserved foods, to the American pattern.
Presenting with high rates of colon and breast cancers, driven by high saturated fat and low fiber intakes.
It proves that environment can entirely override historical population genetics.
Which brings us to a crucial conceptual reframing for you as a future physician.
This is important.
We throw around the phrase preventing type 2 diabetes or preventing heart disease. The source material explicitly states we need to abandon that word and reframe our clinical goals around risk reduction and delay.
Right, because there's that old medical adage, genetics load the gun, but the environment pulls the trigger.
Exactly. If you have a patient with a massive familial history of type 2 diabetes, their beta cells might be genetically destined to fail eventually. A perfect diet and exercise regimen might not prevent the disease entirely.
But if that healthy lifestyle delays the onset of the disease by 15 or 20 years, that is a monumental clinical victory.
It's huge. That's 2 decades of normal vascular function. 2 decades without peripheral neuropathy, without diabetic retinopathy blinding them, without nephropathy destroying their kidneys.
Delaying the onset is the victory, but how these chronic risks actually manifest is heavily dictated by biological sex, driven by the distinct hormonal landscapes we discussed earlier.
Let's look at women's health first as they transition from their reproductive years into menopause.
During the reproductive years, that continuous monthly blood loss means they have a high non-negotiable need for iron. But as they hit menopause, the ovaries cease production and circulating estrogen levels just plummet.
And that loss of estrogen triggers 2 profound, dangerous metabolic shifts.
What's the first one?
First, estrogen is a powerful inhibitor of osteoclast activity, the cells that actively break down bone. Without estrogen, osteoclast activity goes unchecked, bone resorption accelerates drastically, and the risk for osteopenia and osteoporosis spikes.
Second, estrogen dictates fat distribution, right?
Yes. During the reproductive years, it promotes a gynoid fat distribution, storing fat subcutaneously in the hips and thighs. This fat is relatively metabolically inert and is actually cardioprotective.
But post-menopause, the lack of estrogen causes a stark shift. Fat storage redistributes to the central abdominal area, creating an android distribution.
This visceral fat basically wraps around the internal organs.
And visceral fat is not inert. It is highly lipolytic. It dumps free fatty acids directly into the portal vein, leading to the liver.
Which drives hepatic insulin resistance and systemic inflammation, directly raising cardiovascular risk.
Now let's look at the male trajectory. Their physiology is driven by testosterone, which sustains a higher proportion of lean muscle mass.
This gives men a higher basal metabolic rate, meaning they generally need more absolute calories and protein than women.
But from a risk perspective, men are actually at a disadvantage early on. They have a natural tendency toward that dangerous android visceral fat distribution right from puberty onward.
Right. And because they lack the cardioprotective effects of estrogen, and they carry that metabolically active visceral fat, men are at a significantly higher risk for cardiovascular disease events like myocardial infarctions much earlier in life compared to women.
The source material also points out a male-specific risk regarding prostate health as they age. But uniquely, the intervention here is highly specific to certain phytochemicals.
The slides really emphasize the protective role of lycopene, which is a powerful antioxidant found heavily in cooked tomatoes.
Lycopene specifically concentrates in prostate tissue, right? And protects the cells from oxidative DNA damage.
Yes, so a diet rich in lycopene, alongside cruciferous vegetables like broccoli, which contain compounds that aid in detoxifying potential carcinogens, that is strongly protective against prostate cancer and benign prostatic hyperplasia.
But this brings up a huge psychosocial barrier that we just have to address. As a clinician, you can know all the biochemistry in the world, but if your patient won't listen to you, it's useless.
Completely useless.
And there is a pervasive toxic masculinity factor here in how men approach their health.
It is a massive epidemiological variable. Traditional masculine norms often dictate that caring about a balanced diet, eating salads, or proactively going to the doctor for a checkup is somehow perceived as unmanly or weak.
Right. The cultural messaging is that a real man eats a massive steak and drinks a six-pack. Right.
And it directly translates into the behavioral data we see. Men have significantly higher rates of red and processed meat consumption, much lower intakes of fruits and vegetables, and vastly higher rates of excessive alcohol use.
So if a male patient views your nutritional counseling as a threat to his masculine identity, he will simply reject it.
You have to understand these cultural barriers to effectively communicate risk and motivate actual behavioral change.
Which perfectly sets the stage for our final physiological chapter. We survive the slow burn of adulthood and we enter the conservation phase. Aging, sarcopenia, and sensory decline.
We are living longer than ever in human history. But the source material draws a very sharp, very important distinction between life expectancy and lifespan.
Okay, break that down. Life expectancy is the average number of years a population is expected to live, right?
Yeah.
And modern medicine, antibiotics, surgical interventions, they have pushed that number incredibly high.
But lifespan is the absolute maximum biological limit of a human body. And that has remained essentially unchanged at around 110 to 120 years.
So our clinical goal in geriatrics is no longer just adding years to life. It is the compression of morbidity.
Yes, squeezing the period of functional decline, illness, and frailty into the absolute shortest possible time frame at the very end of life.
But to achieve that compression, we have to combat normal physiological aging. And the primary and most devastating enemy here is sarcopenia.
Sarcopenia, the progressive, age-related loss of skeletal muscle mass and strength.
The slides state it starts insidiously around age 40, and you lose 2 to 3% of your lean muscle mass every single decade.
It is the single most impactful physiological change on an older adult's nutritional status. As muscle mass declines, the basal metabolic rate just plummets.
Meaning their daily energy needs decrease by about 10 kilocalories per day for every year after age 19.
Exactly.
You know, I think of sarcopenia like a hospital running on a backup generator. The system realizes it doesn't have the overall metabolic power it used to, so it starts shedding non-essential load, in this case, skeletal muscle, just to keep the vital organs running.
That's a great analogy.
But by shedding that muscle, the structural integrity of the entire patient is compromised. They become frail, their balance fails, and suddenly a simple fall becomes a fatal hip fracture.
That is a highly accurate clinical metaphor.
Yeah.
And the loss of muscle creates this brutal paradox in aging nutrition.
How so?
Because their metabolism has slowed, seniors need significantly fewer calories overall to avoid gaining fat. However, their aging gastrointestinal tracts become far less efficient at absorbing nutrients.
So they actually need higher concentrations of specific vitamins and minerals in the food they do eat.
Exactly. And they need significantly more protein to fight off that sarcopenic muscle loss.
Right. The standard adult RDA for protein is 0.8 grams per kilogram of body weight.
But older adults develop what is called anabolic resistance. Their muscles just do not respond as efficiently to the amino acid signals to synthesize new tissue.
To overcome this resistance, experts recommend older adults actually consume 1.0 to 1.3 grams of protein per kilogram, heavily skewed toward high-quality proteins rich in leucine.
Combined with resistance training to actively force the muscle to synthesize.
But getting those nutrients in is complicated by the biological erosion of the gastrointestinal tract itself.
Yes, it is.
The most critical GI change highlighted in the slides is atrophic gastritis, which affects roughly 30% of older adults.
Atrophic gastritis is the chronic inflammation and eventual death of the parietal cells in the stomach lining.
And the parietal cells are responsible for secreting hydrochloric acid, an intrinsic factor.
Precisely. And why is that hydrochloric acid so important? Because the natural vitamin B12 found in animal products like meat and dairy is tightly bound to dietary proteins.
Oh, I see.
You absolutely need strong, highly acidic gastric juice to denature those proteins and cleave the B12 off so it can even be absorbed.
So without the acid, the B12 remains locked to the protein and just passes straight through the digestive tract.
Right. And without the intrinsic factor, even if the B12 was free, it couldn't be absorbed in the terminal ileum anyway.
This is a vital clinical pearl for you as a medical student, because these patients cannot unbind natural B12 due to the lack of acid. Synthetic B12, which is already in an unbound, free form, becomes a strict medical necessity.
You must recommend fortified foods or a synthetic B12 supplement to prevent the irreversible neurological damage and macrocytic anemia associated with B12 deficiency.
And it's not just the stomach that's failing, it's the sensory inputs too. Their sense of taste and smell blunts, which massively reduces the joy and desire to eat.
But the most dangerous sensory decline is their thirst mechanism.
Because the osmoreceptors in the hypothalamus become less sensitive to the hypertonicity of their blood.
Meaning they literally do not feel thirsty even when they are clinically severely dehydrated.
As a doctor, you often have to prescribe water intake to an older adult, just like you would prescribe a blood pressure medication on a set schedule, because you cannot rely on their internal cues.
And we cannot look at geriatric nutrition in a biological vacuum.
Yeah.
The psychosocial realities of aging are often the ultimate determinant of health.
The slides introduce this really helpful screening tool called the Determine Checklist.
DETERMINE.
Right. It stands for disease, eating poorly, tooth loss, economic hardship, reduced social contact, multiple medicines, involuntary weight loss, needs assistance, and elder years above 80.
You can prescribe the perfect diet, but if an isolated senior is living in poverty, relying on a fixed income, suffering from depression due to the loss of a spouse, and wearing poorly fitting dentures that make chewing meat agonizing, their cellular biology is irrelevant.
They are at a massive nutritional risk due to their environment.
Polypharmacy alone, taking 5 or more medications, can radically alter taste, cause dry mouth, and induce nausea.
It's the ultimate convergence of biology and sociology. And there is one final fascinating clinical twist regarding weight in older adults that completely upends what we are taught in our early years.
I love this part.
We spend our entire adult lives trying to keep our BMI down to reduce cardiovascular risk. But for seniors, the paradigm totally flips.
The slides explicitly note that for older adults, being slightly heavier, maintaining a BMI of 19 to 27, is actually protective. It is associated with lower mortality.
Because that little bit of extra padding provides a crucial metabolic reserve against the catabolic stress of an acute illness, like pneumonia or a severe fall.
Unintentional weight loss in a senior is one of the most terrifying red flags in geriatrics. It immediately signals frailty and impending mortality.
It completely flips the script on how we view a healthy weight.
It really does.
So let's pull all these threads together. We have just traversed the entire human life cycle. From the preconception lockdown of the HPG axis in the face of metabolic stress to the critical, non-negotiable 21-day window of neural tube closure.
We've navigated the hormonally driven, rapid expansion of adolescence and the treacherous, deceptive clinical waters of eating disorders.
We've mapped out how the loss of estrogen and the rise of visceral fat-shaped lifestyle diseases in adulthood, and finally, how the slow sarcopenic erosion of aging forces us to entirely rethink protein synthesis and nutrient absorption.
The ultimate takeaway for a medical student is that context is everything. You cannot standardize a single healthy diet. The patient's exact stage in the life cycle dictates their metabolic reality, their risk factors, and your clinical intervention.
And to leave you with one final provocative thought to chew on before your next rotation, the source material briefly mentions a concept called fetal programming, often related to the Barker hypothesis.
It's the idea that a mother's nutritional status, or even a grandmother's nutritional status during her pregnancy, can epigenetically alter fetal gene expression.
Think back to that Dutch famine we started with.
Exactly. The women who survived that severe starvation gave birth to children who had altered metabolic genes. The famine actually methylated their DNA to expect a world of severe scarcity.
When those children grew up in a post-war world of caloric plenty, their bodies aggressively hoarded every calorie, leading to massive, unprecedented rates of obesity, insulin resistance, and type 2 diabetes.
It is a profound realization about the deep, intergenerational impact of nutrition.
Which means the chronic lifestyle disease you might be trying to treat in a patient tomorrow morning might actually have been programmed into their epigenetics by a famine their grandmother endured 3 generations ago.
The diagnostic landscape is constantly shifting, and the X-ray machine won't save you here.
Thank you for joining us on this deep dive into the life cycle of nutrition. Take this perspective, carry this lens with you onto the clinical wards, and remember to look at the whole patient, context and all.